Hello, everybody. My name is Omar. I am the advisor for HIV treatment and care at the Pan American Health Organization, the regional office for the World Health Organization for the Americas, and also the representative for Latin America at the Governing Council of the International AIDS Society. Welcome to everybody to this webinar on advanced HIV care in the Caribbean, strategies to reduce preventable HIV deaths. It's a pleasure to be here today moderating this webinar with my friend Shanti Singh Anthony. Shanti is the knowledge coordinator and PANCAP. At the global level, opportunistic infections continue being particular common and a significant and common and frequent cause of death in patients with HIV. In spite of having the tools for reducing the new incidents, the new infections, but also the tool to eliminate the HIV-related death, this continue being a frequent situation. In addition, the Caribbean is the second region in the world after Africa in terms of high prevalence, but also it's a region where we have a lot of opportunities to advance in the concept of HIV elimination that include the reduction of the new HIV cases to 90%, but also the reduction of the deaths produced for HIV to 90%. The aim for this webinar is to improve your understanding of the latest advancement in managing advanced HIV disease by exploring an expanded package of care for this condition, highlighting the importance of optimizing the screening, diagnosis, and management of histoplasmosis among people with HIV, sharing insights about improving tuberculosis prevention through shorter, more effective preventive options. And also, the webinar will explore strategies to reduce the mortality from cryptococcal disease and histoplasmosis. So for me, it's a pleasure to welcome today the speakers that include Ajay Rangaraj from Switzerland, Alessandro Pasqualotto from Brazil, Elena Vogt from Switzerland, Joe Jarvis from UK and Botswana, and Veronique Martin from the UK. So it's my pleasure to introduce Shanti, that will be coordinating this webinar presentation with me. Shanti?
Thank you, Omar. Good morning, everyone. Good morning, everyone, and thank you, Omar. It is my pleasure to co-moderate this really important session with you today. As Dr. Omar said, I am the coordinator for HIV knowledge management for the Caribbean with the Pan-Caribbean Partnership Against HIV and AIDS, PANCAP, at the CARICOM Secretariat based in Georgetown, Guyana. Thank you all to all of our speakers for being here with us today, and thanks to all of the attendees for being here. Our team will be posting each speaker's bio in the webinar chat box at the start of their presentation so that you can get to know them a little bit better. I want to take the opportunity at this time to thank our donors, particularly Viv Healthcare and Gilead Sciences. Before we go into the presentation, let me share with you a few housekeeping notes. Please note that due to the number of attendees, all participants are currently muted. We have a planned time after the presentation for a Q&A session. Please send any questions that you may have for our speakers focusing on today's topic in the Q&A box at any time. If your question is for a specific speaker, please indicate their name when typing the question. You will also know that there's a thumbs up symbol when someone will ask a question in the Q&A box. If you have a similar question or find this question really important, please click on the thumbs up sign. This will help us to prioritize the questions. In case you're having any issues on Zoom, you can find additional guidance provided in the chat box. Please also send us any technical questions that you may have there. In the chat box, feel free to also let us know from which country you're connecting and what time it is for you. We love seeing your interaction in the chat.
Thank you very much, Shanti. It's a pleasure to share this webinar with you always. So our first presenter is Ajay Rangaraj, who is the focal point in advanced HIV disease and technical officer at the World Health Organization in Switzerland. Ajay will be presenting on expanded package of care for advanced HIV disease. So Ajay, the floor is yours.
Thanks, Omar, and hi everyone, and very happy to be here. I'm just gonna go into presenter mode. Just give me 1 second. And I hope you can see that I'm in presenter mode now, the right mode rather. All right. So the topic I was assigned was about expanding the WHO HD package of care and where we are headed as far as advanced disease is concerned. And I know that the speakers that follow are going to cover a number of sort of specific subtopics that sit under advanced HIV disease. So I'll try to not go too much in detail into each of the opportunistic infections. But just to say, just as a recap, as you know, advanced disease is defined as any person living with HIV with a CD4 cell count of less than or equal to 200 cells per millimeter cubed, or presenting with the WHO stage 3 or 4 age-defining illness. And of course, children under the age of 5 are all considered to have advanced HIV disease and presentation. So this is a quick snapshot, and it's likely you have seen a version of these snapshots over the last few months. But this is just to really provide a sort of baseline upon which we can base our discussions. And it's worth saying that for a number of the opportunistic infections that guidance already exists, there has been a slow uptake in a number of countries to implement these interventions. So there's a number of topics that would be relevant here, and first and foremost of which would be CD4 testing. HIV-associated TB is the next, cryptococcal meningitis, and then particularly in the region of Americas, histoplasmosis becomes a much more important opportunistic infection when compared to sub-Saharan Africa or Asia. So needless to say, these are all very important aspects of care, and I think access to all of these various testing modalities that would help diagnose these conditions as well as preventive prophylaxis is not uniformly available globally. The other thing I wanted to briefly cover to sort of set the context is to talk a little bit about the causes of hospitalization among people living with HIV. This is a systematic review that's currently underway and will be published in a couple of months. But just generally to say that this is based on a systematic review that was done back in 2015 that looked at available published evidence from 2007 to 2014. So the idea was to capture any significant updates since that time interval. So needless to say, this is just a quick summary of the method, which I won't get into, and I'm happy to share my slides at the end. And also, I think there was wide representation. We have a significant number of studies across the Americas, which we also took into consideration. And in short, these were the key causes of admission, and really 42% still are AIDS-related admissions, and of which 19% is TB. And then, of course, a number of diseases that follow, including PCP pneumonia, cryptococcal disease, toxoplasmosis, CMV, and several others. NCDs were still somewhat less common across the board, across all regions. So this is a slightly more complicated slide, but I will focus on the AMRO region, and you can really see that AIDS-defining illnesses, particularly in the south, which we sort of divided into north and south, noting that there were some health system differences across, even within the Americas, and you can really see that AIDS-related death admissions are significantly higher in the southern AMRO region, and of course, TB, PCP, cryptococcal meningitis, bacterial infections, pneumonia, some of the key causes of admissions. We also looked at a description of the deaths that were reported in this study, and in the meta-analysis, we found that about 17% of these admissions resulted in mortality. And needless to say, in ICU cohorts, this was significantly higher at 53%. Of course, it's worth saying that we didn't have individual patient data as a disclaimer, and also different definitions and lack of standardized definitions for some of these disease categories as well would present a problem. And of course, there's a limited number of studies in certain regions as well. And then comparing the previous period with the current period of the review, you can see that there are more people who took ART. It's 43 versus 56 now. But age-related admissions still predominate. Hospitalizations among people living with HIV and death is still quite high. So having set the context here, some of the things that we worked on, and I can say that my colleague Joe Jarvis was instrumental in putting this piece of work together, which was about looking at the advanced HIV disease research landscape. And this is just a quick snapshot of what we found, which would help us construct a roadmap on when WHO should respond and consider doing scoping activities or actual guidelines on advanced disease. And you can see here that as of 2024, we're interested and looking at a number of areas that include CD4 testing, tuberculosis, tuberomycosis, and Kaposi sarcoma. And going into 2025, 2026, we do anticipate new guidance in TB, PCP, rather study results are expected in this time period. And we are still pending further information on toxoplasmosis and CMV, but noting that they're important diseases as well. And of course, tuberomycosis and histoplasmosis. And then we also are looking at severe bacterial infections into 2027, 2028, anticipating results of an important ongoing trial, which I will speak about briefly. So we also conducted a scoping consultation earlier this year following the publication of this research landscape. And this was really to help narrow down key topics that could help identify which of these topics WHO should do guidelines on. So the research landscape sort of identified the width of research that's ongoing across a number of key focus areas that are related to advanced disease, and this narrows down into specific questions. So of course, CD4 was considered a very high priority. Inpatient management was another secondary priority, along with alignment of the use of lateral flow assay, understanding the use of the semi-quantitative cryptococcal antigen, of course, severe bacterial infections and the revive trial with azithromycin, as well as a regionally relevant question, which is routine screening for histoplasmosis, and a potential scoping review is being considered for this. And of course, the preferred management approach for Kaposi sarcoma, and a number of other topics as well that include post-discharge interventions for hospitalized PLHIV. And what we're looking at in terms of potential expansions into 2025 is, of course, we're currently working on an update of terminology of advanced disease versus AIDS in Q1 and Q2 of 2025. This is an important piece of work and really is a response to a strong community demand for clarity around the use of the terminology of advanced disease versus AIDS. So a Delphi process is currently underway, and round one is thus far complete. And we also have we are looking to develop new recommendations on the preferred approach for identifying AHD in people living with HIV, which essentially is comparing CD4 testing versus clinical staging. Of course, we're looking to develop recommendations for post-discharge interventions in those who are being discharged from hospital following a period of hospitalization, what the preferred treatment for Kaposi sarcoma is. And you might be aware already, but the WHO Global TB Program working with us has released new guidance for molecular testing for TB in people living with HIV, where there will be, which is now recommended as a parallel test, which means that you would do a sputum expert along with an LF-LAM urine for all people with advanced disease, whether they're in hospital or in outpatient settings. Other related areas is that there are ongoing evaluations on the use of point-of-care CD4 particularly. I think we are also considering a scoping exercise, of course, working with colleagues such as Omar on routine histoplasmosis screening in people living with HIV. We would need to develop some considerations around the use, management of non-tuberculosis mycobacterium. We're looking to develop an AMR framework for advanced disease on the non-ARV antimicrobials, as there are a wide range of these. And then, of course, in collaboration with the mental health department at WHO, we're in the scoping process of developing recommendations for neurocognitive disorders in people living with HIV. Needless to say, there are still significant areas of work that are in the process of being updated. There are newer areas that have been identified for the investigation, And I think ultimately due consideration should be given to balance the need and complexity of implementation of various diagnostics, prophylactics, and treatments. And this really underscores the importance of advanced disease, how it spans the health system, both in inpatient and outpatient, the broad range of opportunistic infections that need to be managed, and also the rapidly increasing proportion of people presenting to care with advanced disease, because many of these individuals have previously received ART, they disengage and then re-engage back in care. And in most programs, this number is around 30% at presentation will have advanced HIV disease. Yeah, so with that, I'll end. Thank you.
Thank you, Ajay, and thank you for stick to the time. We will have question at the end, so please to those please stay, Ajay, and please those that has some question, you can use the chat, the QS icon below. So thank you very much, Ajay. I will be now introducing the next speaker. Alessandro Pasqualotto is an infectious disease specialist and professor at the Universidade Federal de Ciencias da Saude de Porto Alegre and head of the Molecular Biology Laboratory and Infectious Disease Service at the Santa Casa de Porto Alegre in Brazil. Alessandro will be speaking on the impact of optimal screening, diagnosis, and management of histoplasmosis among people living with HIV. So thank you very much for being here, Alessandro, and the floor is yours.
Hello, good morning, everyone. Can you listen to me? Are you hearing me?
Perfect. Yeah, thank you.
All right. Thanks for the invitation, Omar and all of colleagues. So it's a big challenge to cover such broad areas in histo. I'll just ask you please to pass my slides as I keep speaking. So histo is clearly a disease that is associated with advanced HIV disease. Next, please. We know that histo has been a AIDS-defining disease since the 1980s, but there's a lot to do in terms of understanding this condition. Next slide, please. Histo nowadays kills more people in the Americas than TB in the HIV population, which is quite impressive because we have a lot of programs and money and efforts dedicated to TB, but fungal diseases remain neglected in the continent. Next slide, please. And there has been an expansion of original geographic areas for histo. Next slide, please. As you can see, originally we used to speak of histo as a disease of the United States, of the Mississippi and Ohio rivers, but that has changed a lot more recently. And now histo is a global disease. It's everywhere in the American continent, in several areas of Brazil, in Central America and Africa, Southeast Asia, and some parts of Australia and Europe as well. So it's not an endemic disease, it's a global disease. Next one, please. We have done a study in Brazil. Next slide, please. Basically screening patients with HIV in the hospital with fever and something else, like a manifestation of disseminated disease. So more than 500 patients included in the study. And next, please. We were able to find histo in more than 20% of patients using urinary antigen. So when we have the tool available, we make a proper diagnosis. So disease is just there. We are just not finding because we're not using the proper diagnostic tools. Next slide, please. But it's not the same in every region of Brazil. Like in Porto Alegre, where I live, like 8% of HIV patients in the hospital with fever have histo, but in other areas of Brazil, like Guyana and Fortaleza, Natal, is more than 40%. So it's highly endemic in some hotspots in Brazil and probably all other countries as well. Next slide, please. And clinically, it looks like TB. Some people say it's very similar, but to me, it's quite different from tuberculosis. But because the lower the CD4 count the patient has, as you can see in these slides, the higher the prevalence of histo in comparison with TB. So histo is more like an advanced opportunistic infection occurring in patients with very, very low CD4 counts. Median CD4 count is usually 25 in these patients. And TB is more like a pleural pulmonary disease, while histo disseminates and involves spleen and liver and lymph nodes. Next slide, please. and also patients have abnormal liver function and pancytopenia. So, and to me, it's not difficult to think of histoplasmosis because, next slide, please, it commonly goes to the skin, which is something that TB doesn't really do, and to the oral mucosa, gastrointestinal tract. So we need to think of histoplasmosis in advanced HIV infection. Next slide, please. So why diagnosis is so difficult? You can see here that it's a very slowly growing fungus. It may take weeks to grow. We need appropriate biosafety to grow histo. And we rely on invasive medical procedures, bone marrow aspiration, BAL, that is frequently not available in many of these countries. So what if I say that we can make diagnosis on the same day? So this is a game changer. We have now access to histoantigen testing, and it's an amazing test, such like the cryptoantigen testing, the PREG, because it's very high. It has very high sensitivity and specificity. This is for disseminated disease. So if the patient is severely ill, highly immunosuppressed, we need to have access to histoantigen testing. Next slide, please. This is clearly shown in the PAHO and WHO guidelines. The next, please, saying that if we are aiming for diagnosis, what we need is access to histoantigen testing, and that's it. We still need to do classical mycology, but histoantigen testing is it's critical, very important. We did a study quite a long time ago, in 2019, looking at Latin America to see and the Caribbean. How many countries were able to do diagnosis of fungal infections? Next, please. And as you can see here, histoantigen testing was available for about 20% of centers. We are updating this data now, but I won't be surprised if that hasn't changed much, because we have access in Brazil for histoantigen testing for research, but it's still there. It's still not there in the public sector. Next, please. So with that in mind, we organized a histo meeting here in Porto Alegre, and we decided to write like a political paper saying that, well, we have a very advanced HIV program in the country, so everybody has access to free antiretroviral therapy, but many patients arrive with a very late disease, and they present with this opportunistic infection, such as histo, and we do need access to two things, which is histoantigen testing and liposomal amphotericin B. So this is what we published in this article. Next, please. So what about treatment? Next slide, please. So again, we have the PAHO and WHO guidelines, and also the ECMM and ESHAM guidelines saying the same. So it's easy. Once you have the diagnosis, next, please. We need to go for liposomal amphotericin B for 2 weeks for induction therapy, and then follow. Patients will be taking itraconazole for a year. Maybe it's too long, but that's the current recommendation. So if disease is mild, we can use itraconazole, but it's really hard to separate mild from moderate. So if disease is moderate to severe, definitely we need IV drugs, and liposomal amphotericin B is the optimal drug at the moment for that. Next, please. Recently, we published this was a phase 2 trial based on the knowledge we had with cryptococcal infection. Why don't we use a single high dose of amphotericin B, of liposomal amphotericin B, for induction therapy of histo, just a single dose of 10 milligrams per kilogram. This was published in CAD, I think, last year. Next, please. And just to summarize, we show that the clinical response at day 14 was basically the same, slightly better for the single high dose arm. Survival was the same, and the frequency of toxicity was slightly lower for the single high dose. So this is a strategy that may be relevant for the future. Next slide, please. We are about to start a phase 3 trial now. That it has been approved. We have money to run the trial. We'll be doing this in 17 centers in Brazil. Next, please. But this time we're going to look for overall survival instead of clinical response, because it's just easier to measure and as a primary endpoint. So clinical response is going to be secondary endpoints in addition to toxicity and decrease in histoantigen titers. But we're also going to look to DOR analysis. For those of you who are not familiar with DOR, So it doesn't really matter only if the patient survives or dies. We need to see if the patient survived with or without a major toxicity. So we hope to prove with that the single high dose of Amazon is as efficacious as the standard 2-week dose of Amazon. And with that, we can save a lot of money and improve access to treatment all over the country. Next, please. I'm about to finish just to show what we will be doing in the future. Next, please. So this is the histofactorial trial. We will apply for NIH grants. Basically, the first randomization is going to be induction therapy, single high dose versus 2 weeks of therapy. Then we're going to randomize patients again for 3 arms. So consolidation therapy with itraconazole, which is the standard of care, versus prothioconazole and izabuconazole, and then randomize patients again for 6 weeks versus 12 weeks, 6 months, sorry, versus 12 months. Hope we can do this study in the near future. Next, please. So this is a very important question. So why don't we screen patients with histoantigen if the test is so good? And we treat these patients and we eliminate histo and avoiding them to arrive hospitals with disseminated infection. Next slide, please. So this is basically what I'm sorry, this is in Portuguese, but this is what the Ministry of Health is currently recommending in Brazil. I'm just going to translate this to you. So if the patient has low CD4 counts or advanced HIV disease, as you can see here, stage 3 or 4 WHO, and if there is no symptom, the Ministry of Health is recommending screening these patients with histoantigen, and if histoantigen is positive, to treat them preemptively with itraconazole. But let me say that, next slide, please, there is absolutely no evidence for that. There is no data supporting the use of histoantigen for a screening strategy for patients with low symptoms, with mild symptoms, or with symptomatic patients. Well, I think this has been taken from crypto and put on histo, but we don't understand the national history of histoplasmosis in AIDS. So if you have access to histoantigen, let me say, my suggestion is that we should focus on those who are severely ill, those in hospitals, because the histoantigen testing that has been proved to be a very nice strategy for this scenario, for disseminated disease. Next slide, please. So in conclusion, I would like to reinforce the relevance of histo in advanced HIV disease, and we need to improve our work in terms of providing awareness for this condition and to have effective programs to prevent and to treat and diagnose histoplasmosis. We need access to histoantigen testing and liposomal amphotericin B, particularly for patients in the hospital, but we need to decentralize that. We need every large hospital in the country with access at least to histoantigen testing detection by ELISA. And I would like to say that universal screening at the moment is not recommended because there is no data that treating this patient is better than just giving them antiretroviral therapy. Thank you very much. This is my last slide, I think, and I'm happy to take your questions.
Thank you very much, Alessandro. So I will invite Shanti to introduce the next speaker. Shanti, if you can continue.
Sure. Thank you so much, Dr. Ajay and Dr. Alessandro. Thank you both for your presentations. I have now the pleasure of introducing Yelena Vuk, who is a medical officer, HIV, TB, comorbidities, and quality of care at WHO Switzerland. Dr. Yelena Vuk will be presenting on lessons learned from countries in scaling up shorter regimens for TB prevention. Over to you. Thank you. Could you go on slideshow, Dr. Yelena?
Yes. I hope you see my slide.
Yes.
Thank you. So thank you very much for this initiative and for giving a little time to also reflect on one of the strategies to prevent TB deaths in people living with HIV. And one of the strategies is certainly TB preventive treatment. That we had the great honor to be supported also by the Global Fund to work in a multi-country strategic initiative, about which I will tell you in a few words what we learned from working with countries and how this evolved over 3 years of implementing the project. So first of all, to start with, despite the fact that we reached the target of putting more than 6 million people living with HIV on TB preventive treatment by 2022, we still have some targets to achieve by 2025. And the TB preventive treatment is being kept high on the agenda of the WHO. The targets to be reached by 2025 and 2030 are both in our global health sector strategies on HIV, viral hepatitis, and sexually transmitted diseases by 2030. That was developed by our Department of HIV, Hepatitis, and STIs, and also in the end TB strategy. Despite the progress that we see overall globally, that more people are being put on antiretroviral treatment, the cumulative number of people living with HIV receiving TPT is increasing globally. We still see since 2019 that specifically TB preventive treatment in people living with HIV annually is decreasing. So the numbers of those that are put on TB preventive treatment are increasing in households, contacts aged more than 5 years old and less than 5 years old. But we unfortunately see less people living with HIV being put on TB preventive treatment. And with this in mind, a big effort by WHO and Global Fund was done to offer to a number of countries to benefit from the technical assistance the WHO and Global Fund was offering within a TB preventive treatment strategic initiative that we implemented overall in 17 countries. We had 9 countries in the first 2 years of the project, and then later on in 2023, we had additional countries that have joined, and you have the list of the countries listed. So mostly we focused certainly on countries in the African region, but we also had Dominican Republic that expressed the willingness and being also on the list of the countries that was eligible for help from the Global Fund. We had a small component in Dominican Republic and some of the Western Pacific regions like Thailand. So the project combined basically a couple of interventions. We were offering countries that they could go for a full package of interventions or just a few of them, including either revision of national guidelines and protocol development, the TPT search, planning and implementation roadmap, which is basically a strategic document that could put together either benefiting from an additional consultancy supported by Global Fund and WHO, or through some meetings and internal workforce of the country to develop a search plan and put the acceleration plan in motion in the country. Either capacity building for healthcare workers to accelerate the understanding of how we implement and scale up the use of shorter regimens of TB preventive treatment in people living with HIV, procurement and supply management, data collection, analysis and monitoring of data, community engagement for service delivery, and any other emerging or contextual needs identified by the country. So these were the components, and you see in the table basically that different countries went for a different package. And that was by their choice based on what they already have developed in the country, or maybe it was supported by additional donors externally. Now, our aim was basically globally to boost the number of countries that are reporting on TPT initiation and TPT completion rates as well, and to increase the number of countries that revise the guidelines to include the shorter regimens. And the shorter regimens, you have them in this table here to just remind you. You can definitely see that basically we do have a lot of countries that are reporting initiating. Look on the right side of the slide for the 2020 and 23, you can still see as marked that the implementation and the use of the shorter regimens like the 3HP weekly regimen that is taken once a week during 12 weeks is not exactly fully implemented in many countries. With our project, we managed to increase the number of countries that were reporting initiation, and some of the countries also appropriate completion of treatment. However, there is more work to do to see that countries really update and adopt their recommendations, basically to use the shorter regimens as priority and to assure completion and adherence to treatment. Here you can see how we were monitoring the uptake of WHO recommendations in countries, basically looking at what regimen is recommended for adults and children as priority and overall in the recommendations. And in 2 years, we managed to boost the policies changes and policies endorsements in countries, in most of the countries. And we also looked at the possibilities to help with any stockouts of important TPT regimens. And we were documenting them also through the Global AIDS Monitoring Tool, that is a global reporting tool from countries. TPT as component of advanced HIV disease package was implemented pretty well in most of the countries. So 15 of our 17 countries implemented to be preventive treatment as a part of advanced HIV disease. And I have to congratulate my colleagues that work on AHD that the uptake of the package is going quite well in a number of countries, especially those that were part of our initiative as well. From countries, we heard that pre-surge planning assures a better implementation. So that means that not only developing a roadmap to accelerate the scale up of the use of shorter regimens and the scale up of TPT in the country, but actually preparing very well before you start, before those a couple of months when you start an active implementation in all the sites is very important. Countries were also telling us that basically they had a lot of choices. They had the 6 months regimen, they had the 3 months regimen, rifampicin-based and the rifampicin-based. And sometimes it was creating problems because there were too many choices without mainstreaming the preferred option. That was also due to unavailability sometimes of short regimens that came only in 2022, 2023 with a big donation from UNITAID and then started being put in the national procurements under the Global Fund and the PEPFAR funded projects. We had a couple of good examples from countries like Eswatini that also worked on quality improvement tools for monitoring the TPT and implemented gradually also their search plan. And we also have seen a very good performance of the program by Zimbabwe that increased the TPT scale up from a couple of tens of sites to more than 1,000 sites. Some countries were specifically also reporting that for them, the scale up works much better if they try to pilot first at a couple of districts and a couple of facilities. And then with the joining, with the support and collaboration from other partners, they scale up through the country to more regions. Definitely one common were introducing 3HP as one of the short regimens alongside of the 6H, the 6 months regimen. And only after that, they were ready to move to a gradual full transition to the shorter regimens. So from the lessons learned and technical considerations, many countries were concerned with the monitoring and evaluation approaches because various sites were using various different evaluation and monitoring tools, and that was hard at the national level to harmonize. So the need of harmonization was there. There was a Prevent TB app that was offered by WHO along with other digital applications offered by other partners. And then the countries had to decide which way they go to incorporate these digital applications into their national monitoring systems. We had challenges being expressed, being reported from countries that not always the fixed dose combinations were available and remained a concern. And the TPT policies in most countries were updated either on the TB side of the guidelines or the HIV side of the guidelines, so the silos were still persisting. There were good examples about integrating TPT into the ART provision, and that is definitely aligned with the WHO recommendation of the differentiated service delivery approach. And there were some challenges remaining with the counseling to take the TB preventive treatment. So here as a reminder, our consolidated guidelines by WHO latest version published in full in 2021 that will undergo a revision next year has in the chapter 7 under the service delivery a very clear recommendation that in settings with high burden of HIV and TB-ART should be initiated in TB settings and linkages to care should be followed as well. But also in the WHO operational handbook developed by our global TB program, there is a component of differentiated HIV service delivery and implication for TPT scale up that is specifically reflecting on the fact that there are benefits to offer TPT at points of care where ART is offered, and there are some key elements that should be considered. So in brief, among the lessons learned, apart from the good coordination of partners that gave us a very good overlook also about the prices change, and you can see that the prices dropped for the shorter regimens for 3HP. Now we are at the, about $9 to $10 for the regimen, which is a very good achievement in 2023 that made more access to the shorter regimens in countries. We also collaborated with some partners like KNCV that were implementing a number of capacity building master curricula that could be replicated in countries, and that was also a very good lesson learned. Once you create a master curricula, you can replicate in different countries and just adapt. That was definitely a very good opportunity for us for the new cycle of the Global Fund to make sure that now the ground is prepared with the revision of the policies and the roadmaps being there in countries so that countries could plan for the TPT scale up already for the next 3 years. And definitely the TPT monitoring and evaluation caused many problems, something that we still need to work on. Countries that in big countries, specifically because we have short regimens and people can take home the TPT pills. Basically the problem was that countries are reporting regarding the monitoring. We definitely had a challenge in many countries, and this is a global picture of where we are with initiating treatment, maintaining people that are enrolled in TPT, but also how countries are reporting the completion of treatment. Unfortunately, completion of treatment is still remaining underreported. We know that that countries are scaling up much better than we see globally being reported. And the problem with the reporting being probably also the concerns that countries were telling us about various tools that are being used, or the lack of incorporation of TPT monitoring into the national systems. So here, speaking about monitoring and evaluation, just a reminder that there is an HIV strategic information guideline developed by our Department of HIV, Hepatitis and STIs. And there is the guidance for monitoring TPT initiation and completion by the Global AIDS Monitoring Tool. There is a chapter that specifically looks into how you monitor and report well the shorter regimens uptake. And this chapter will be revised in the next version.
Thank you very much. Thank you very much, Dr. Yelena Vok. I'm reminding our attendees again, please go ahead and submit your presentations. Your questions. That was a very interesting presentations, and we've heard very interesting presentations from all of our previous speakers. So please go ahead and submit your questions. At this time, I'd like to introduce our next speaker, Joe Jarvis. He is a professor of tropical medicine and international health at the London School of Hygiene and Tropical Medicine and research associate at the Botswana Harvard AIDS Institute Partnership. Joe will be presenting to us today on the new evidence in the management of cryptococcal disease. Over to you, Joe.
Great, thank you very much. Let me just share my slides. Great, so hopefully you can see the slide. So thank you for the opportunity to talk today. I'm going to spend the next 12 minutes or so talking about cryptococcal meningitis and just taking you through some of the recent changes in guidelines and evidence. So I'm sure that this audience doesn't need much introduction to this topic. We've already heard about the ongoing burden of advanced HIV disease and the ongoing toll that AIDS-related mortality is carrying. We know that many of the deaths among people with advanced HIV disease are caused by cryptococcal meningitis. So, of course, properly managing cryptococcal meningitis is an essential component of ending AIDS by our 2030 target. When I first started working in cryptococcal meningitis, in most of Africa, the treatment was fluconazole monotherapy. And at that time, we were using doses of between 200 to 400 milligrams daily. And the outcomes with that are really terrible. So 10-week mortality in a study in Zambia of 96%, not really any better than doing nothing. And through a series of studies done in Uganda and Malawi, the dose of fluconazole was escalated to 800 and then 1200 milligrams a day. And that improves outcomes a bit for cryptococcal meningitis, but we're still seeing in clinical trials mortality of around 55% at 10 weeks. So clearly unacceptably high mortality with fluconazole monotherapy. So what else did we have in the cupboard to try and treat cryptococcal meningitis? Well, the only other thing available in most limited resource settings was amphotericin B deoxycholate. However, although this reduced mortality compared to fluconazole, with amphotericin B deoxycholate monotherapy or in combination with fluconazole, we were still seeing mortality in clinical trials of around 40 to 45% in the African context. And part of the reason for these poor outcomes is that giving this drug is very challenging. We're trying to give long intravenous courses of a drug that's very difficult to administer safely and can cause significant side effects in very resource-constrained healthcare settings. Standard courses of amphotericin B deoxycholate are associated with severe thrombophlebitis, and that's a picture of a rather nasty chemical thrombophlebitis arising from an amphotericin B drip. But that can also lead to nosocomial sepsis. And we know from several studies in Africa that we see severe nosocomial sepsis in up to 15% of patients with cryptococcal meningitis, many of them caused by drug-resistant organisms. It can cause infusion reactions. And the conventional amphotericin B deoxycholate formulation is associated with quite severe anemia. We saw a mean drop of 2.3 grams per deciliter over 14 days of therapy in our African studies. It also causes renal impairment and quite profound potassium and magnesium wasting. So there was clearly an urgent need to define safer treatments, and particularly treatments that were appropriate for the settings where most people with cryptococcal meningitis are presenting. So what could we do? Well, one approach would be to look at giving shorter courses of conventional amphotericin B deoxycholate. So we did have some data from animal models. These are data from a rabbit model of cryptococcal meningoencephalitis, showing that given just 3 doses of amphotericin B deoxycholate in an abbreviated course led to about the same outcomes in this animal model as giving conventional daily dosing of amphotericin B deoxycholate. And the box at the bottom in red is showing the fungal burdens in the brains of these rabbits at day 14 of therapy. And you can see that just 3 doses had almost the same effect as 14 doses. So this led to the initial trials looking at trying to shorten the duration of amphotericin B-based therapy. And this was done in something called the ACTA trial, which was published in the New England Journal of Medicine in 2017. And this was actually a relatively complex trial. So I'll just speak you through this in some detail. So the main comparison was between 1 week of amphotericin B deoxycholate and 2 weeks, the conventional course of amphotericin B deoxycholate. But in addition to that main comparison, the investigators also compared the second agent, either fluconazole or flucytosine. So you had 4 arms, 1 week of amphotericin B with flucytosine, 1 week of amphotericin B with fluconazole, or 2 weeks of amphotericin B with flucytosine and 2 weeks of amphotericin B with fluconazole. The investigators also included an all-oral arm with fluconazole plus flucytosine. And the results are shown in the graph there, and I've highlighted the key findings in the red boxes. So the best performing treatment in this trial was 1 week of amphotericin B plus flucytosine with 24% 10-week mortality. So quite a marked improvement on the much higher mortality we'd seen with 2-week courses. And as you can see, the 2-week course in this trial of amphotericin with flucytosine led to, again, about that 40% mortality. So that may seem a bit paradoxical, a bit unexpected. Giving 1 week of treatment led to better outcomes than giving 2 weeks of treatment with the same drug. But actually, that's almost certainly due to the fact that you're getting the same fungicidal activity with the 1 week course of treatment with amphotericin, while avoiding a lot of the toxicity. And that toxicity is obviously leading to mortality. So on the basis of this, the WHO updated guidance to recommend the 1 week course of amphotericin B deoxycholate plus flucytosine, as it leads to better outcomes than giving 2 weeks of the same treatment. However, there is an important caveat, and that is if you look to the left of the 1 week amphotericin B and flucytosine box, you'll see that the mortality with 1 week of amphotericin with fluconazole was very high. So in order to shorten the treatment course, you have to be able to give a good fungicidal second agent in the form of flucytosine. So we can only give these abbreviated courses if we're using flucytosine as a second drug rather than fluconazole. What about liposomal amphotericin B? So this is the formulation of amphotericin B that we would always use in the UK or in the US. It's less nephrotoxic, meaning that you can give much higher doses safely. It's got very good tissue penetration and a very long tissue half-life, meaning that you should be able to deliver highly effective induction therapy with very few doses. And we knew from another infection, visceral leishmaniasis, that you could give just one very high 10 milligram per kilogram dose of liposomal amphotericin and get the same outcomes as giving 2 weeks of treatment. But it hadn't been used in cryptococcal meningitis, mainly because cost was a limiting factor. The cost of a standard 2-week course of liposomal amphotericin was about $5,000 at the list pricing, compared to about $16 for conventional amphotericin B deoxycholate. So a major difference. But we thought that if we could show that short courses could work and we could negotiate reduced pricing, this could become a cost-effective option. So we set out to define the most effective and cost-effective schedules of liposomal amphotericin B for cryptococcal meningitis. The first step of this was a phase 2 study with the primary endpoint of early fungicidal activity, EFA, which is rate of clearance of Cryptococcus from the CSF, as our primary endpoint. We compared standard 3 milligram per kilogram dosing of ambisome given for 14 days to either a single 10 milligram per kilogram dose on day 1, 2 high doses, day 1 and day 3, or 3 high doses, day 1, day 3, and day 7. And you can see at the bottom that the rate of clearance, the more negative the number, the faster the clearance, was actually better with all of the short course high dose arms and with the control arm. And in our formal non-inferiority analysis, you can see that all short course high dose ambisome arms were non-inferior to the standard control given for 14 days. You can see that, in fact, the point estimates for clearing fungus favor the short course high dose treatments. And you can see that there's not really any evidence or no evidence for a dose response effect. It looks like giving that single dose is as good as 2 or 3 doses. You don't seem to gain any additional benefit after giving that very large single high dose. So this formed the background to the main ambition trial. We knew that the ACTA trial showed that 7-day courses of amphotericin could be given with flucytosine. We knew from our phase 2 trial that the single 10 milligram per kilogram dose looked like the optimal way of giving liposomal amphotericin B. So we proceeded to a phase 3 trial with the primary endpoint of 10-week mortality, comparing what was then World Health Organization recommended treatment of a single of amphotericin B deoxycholate given for 7 days with flucytosine to the single 10 milligram per kilogram infusion of liposomal amphotericin given with oral flucytosine and fluconazole. The trial was conducted across a series of sites in East and Southern Africa. We recruited over 800 participants, and the results were published a couple of years ago now in a New England journal. And we showed that the single high dose liposomal amphotericin was as good as the conventional WHO recommended amphotericin B deoxycholate. In fact, we had lower mortality at 24.8% at 10 weeks in the liposomal amphotericin single dose arm compared to the control arm, and it was significantly safer. And in terms of anemia, the main side effect, we saw major differences in rates of anemia, almost 40% severe anemia in the control arm compared to just 13% in the amphotericin arm, in the liposomal amphotericin arm. So this led to a very rapid transition into guidance. The World Health Organization updated their guidelines just 3 weeks after the trial was published to include the single liposomal amphotericin 10 milligram per kilogram dose as their favored strategy. And it was rapidly translated into care, certainly across much of Africa. And this also stimulated quite a bit of activism to try and get access to liposomal amphotericin and to make sure that the cost was at an affordable rate. This is still a work in progress, and of course more work needs to be done to make sure that people with cryptococcal meningitis can actually access the treatment. These guidelines or this evidence is also informing guidelines outside of Africa. We certainly know that in some US and European guidelines now, this is being considered and in Asia and parts of Latin America. Very quickly, in terms of other management for cryptococcal meningitis, it's not just the drug therapy that's important. It's critical that toxicity is managed. Even with the liposomal formulations, we still do see some toxicity. So giving prehydration and electrolyte supplementation is very important to avoid that toxicity. And managing the raised opening pressure that patients with cryptococcal meningitis get is also a key part of management. We make sure that we start or restart ART 4 to 6 weeks after initiation of antifungal therapy in line with the COAT trial recommendations. We heard from Alessandro about screening with antigen testing for histoplasmosis. Well, this was based on what we came up with cryptococcal meningitis. We know that there's quite a long period from exposure and reactivation of latent infection to the development of meningitis. And the hope is that we can break that chain of events by screening individuals for early infection with cryptococcal antigen and then giving them treatment. This was based on some work in South Africa showing that cryptococcal antigen was detectable at quite a high rate, around 5 to 6% of people with CD4 counts below 100, and it was highly predictive of subsequent meningitis. And this antigen screening strategy was helped by the development of the IMI lateral flow assay, a very cheap and highly accurate dipstick test that can be used at the bedside to diagnose early cryptococcal infection. So on the basis of these various strands of evidence, the WHO has included cryptococcal antigen screening for people with advanced HIV disease initiating ART in their guidelines since 2011. And it remains in the current guidelines, but there's still a bit of work to be done. We know, unfortunately, that despite cryptococcal antigen screening and treatment with fluconazole, individuals who are crack positive still have a substantially higher mortality than individuals who are crack negative. And it may be that there are a proportion of cases who have subclinical meningitis that require more intensive treatment. There's some work ongoing using semi-quantitative cryptococcal antigen assays to try and identify those most at risk, and the preliminary data suggest this may well be possible. And several trials are ongoing exploring the utility of stratifying management by cryptococcal antigen titer and looking at more intensive therapy for subclinical cryptococcal infection with either an oral regimen of fluconazole plus flucytosine or with the same single high-dose liposomal amphotericin treatment that we've used in individuals with meningitis. So I'll stop there. Sorry, everyone, slightly over time, but happy to take questions at the end. Thank you.
Oh, thank you so very much, Joe. Very comprehensive, again, presentation on cryptococcal disease, cryptococcal meningitis. Certainly, please go ahead and type your questions in. We'll take the questions at the end. It is now my pleasure to introduce our next speaker, Veronica Martin, who is the principal scientist in the HIV/AIDS reporting section at the UK Health Security Agency. Veronica will be presenting to us today on why and how to measure the causes of preventable HIV-related deaths at the national level. So over to you, Veronica.
Thank you very much for having me today. Sorry, let me just try and share my screen. Okay, hopefully you can all see this. So I'm going to be talking about preventable HIV-related deaths and looking specifically at what we are doing in the UK. Let me see. Sorry, my slides are not moving. Let me see if I can. I might have to do it this way. So why do we need to measure HIV-related and preventable mortality? In the UK and in other parts of the world, with advances of treatment, what we see is that we have more and more people that are getting older. In the UK, we now have over 50% of people living with HIV who are over 50. And we have high treatment coverage and people, I think it's 98% of people are currently treated. So what we also see is that there's an increase in the number of potentially non-AIDS related deaths. So, so here we have data for 2022, for example, where the number of AIDS related deaths were 14%, but actually what we see more of now are non-AIDS cancers. So more and more people are dying of conditions that are due to old age rather than HIV or AIDS. And then finally, there's a huge progress in understanding the impact of HIV on immunology and pathophysiology. So where we've started looking at AIDS-related mortality, now we're looking at HIV-related mortality, and the last bit of the puzzle is looking at HIV-related and preventable mortality. So, and this is what we're trying to do in the UK. So what needed to happen in order to explore HIV-related and preventable mortality? In the UK, in London, and at national level, we started doing HIV mortality reviews, where clinicians would send us would fill in a form with information about causes of deaths, but also the health of the patient around the time of death. And what we've been finding, we've been collecting all of this data in the last few years, and it's been a national program since 2019. It's also helped us top up our HIV surveillance databases. Since 2019, we've been using that data to complement the data that we find in other places. And what we also do since then is we use the CODE protocol. So that's the coding causes of deaths in HIV. And that uses the death certificate data and clinical markers. And I'll explain a little bit later how we use this. And we decide different causes of deaths using this, specific for HIV. And then we also use additional clinical markers from national HIV surveillance. So it might be, were people seen for care on a regular basis? Were people, were their viral loads low for a number of years? Did they have, were they diagnosed with an AIDS-related condition previously? So that's one side. We needed to understand the causes of deaths and collect different types of data to understand better mortality among people living with HIV. But we also needed to have a definition of HIV-related and preventable deaths. And we developed this with funding from Fast Track Cities London. So very quickly, the approach that we took for developing this international consensus definition was to do a literature review, systematic in principle, but we didn't publish it as a systematic review. From that, we developed some draft recommendations. So there were 2 clinicians and 2 public health specialists. And we sent these recommendations to a panel of international experts that refined those into recommendations that were taken to a larger stakeholder meeting. And finally, using the stakeholder meeting findings, plus some discussions via email, we published some recommendations for 2 definitions. So definition for HIV-related mortality and also definition for HIV-related and preventable mortality. How does it work? So the clinicians in each HIV service are submitting reports for each deaths using a standardized form that's been agreed previously. And that was part of the work that had been done through the London Mortality Review and the National HIV Mortality Review. And these forms include causes of death and other clinical markers. We collate this information at national level, and that helps us understand if there are duplications between different clinical services, for instance, or sometimes a person died in one hospital but might have been seen for regular care in another part of the country. And so we can kind of like merge their records in that way. And then all of these records are sent they're first coded using the CODE protocol by one of our public health specialists. And then they're also coded, each of them are then coded in pairs. Clinicians discuss the findings and then send us the final codes decided. We then take all of this information and add this to our HIV databases. And the reason we do that is that, one, it helps us understand all-cause mortality for people living with HIV in the UK. And that's the first yearly national publication we have that comes out in our HIV official statistics. And that was done early October. And then we also publish HIV-related and preventable numbers in our monitoring and evaluation framework, which comes out in December. And for these last 2, we use data from the review, but also data from our own surveillance. And so we need to merge all of this together. Now, the merge is quite tricky. You can see here we have a number of sources of data. At the top, you can see that we actually get clinics to report deaths separately from NHMR. We also get data from ONS, which is our official statistics Office for National Statistics, and they send us some deaths that we then merge with our data sets. And then we do, all of this helps us in that we merge the data from NHMR, and then we go back to clinics and let them know that we have found some additional deaths. And so all of this helps us overall to have a really clear picture of mortality among people living with HIV in the UK. And as I said, we then publish all of this in our yearly national publications. In terms of HIV related, we use the code categories, but we also use separately the causes of deaths. So we kind of like, the definition requires you to look at specific causes of deaths as well as late diagnosis. And that's how we decide on whether death is HIV related or possibly HIV related. Possibly HIV related deaths are then further explored by clinicians. Some remain possibly HIV related. Some might be demoted and others might become HIV related. And then we use HIV related and possibly HIV related deaths and apply the definition for preventable. And that includes looking at the categories already looked at for HIV related, but also any AIDS diagnosis, late diagnosis, ART related events, and also some other treatment and care markers. Like, as I said before, we also look at whether people were seen for care on a regular basis in the previous years. So for 2022, we had 688 deaths reported in the UK in 2022, and that's across all the different systems that I mentioned earlier. Of those, 573 were reported via NHMR. And then, of course, we recommend our clinics to send us more reports for those deaths that were not reported via NHMR, but that were reported via our other systems. And of course, this is all voluntary. Out of those 573 deaths, we had 507 that were matched to our HIV surveillance databases. And we miss some deaths, and that is because we have to match in different ways. We don't hold names in our databases, for instance, or even NHS numbers, which is our national health system. We have to do matching across different characteristics. So it is tricky to match everyone. And then what we also do is we do another exercise where for those people who were not matched, then we will go back to the clinics and ask them if these were new patients that might not have made it through to our other systems. So all of this, again, helps us have a better idea of how mortality is happening in the UK. We have about 79% of deaths that were reported through NHMR that had an ascertainable cause of death. And that's mostly because there is a delay in reporting deaths. There might be issues in accessing reports from coroners. It might also be that we have delays in having causes of deaths. And so that affects the data that we receive. When we look at HIV-related and possibly related deaths, we end up with 103 deaths. Oh, sorry. 65 were HIV-related and 38 were possibly HIV-related. And that's about 25% of the deaths with an ascertainable cause. And then we had 53 deaths that would be considered preventable or potentially preventable. What do we do with this data? So the impact of NHMR and applying those definitions, as I said, has a huge impact on HIV surveillance and how we collect mortality and how we clean up the data that we receive and also how we top up the data. And it helps us have a much better picture of mortality among people living with HIV and also causes of death among people living with HIV. between 2019 and 2022, when we started the voluntary national HIV mortality review process, we have topped up our HIV databases in the UK with 500 deaths, including about 80% of those having causes of deaths. This also has an impact on our clinic's resources because, for instance, when people have died in other locations our clinic might not know, and they're still trying to contact these patients to ensure that they come into care. And so this helps us inform the clinics that people might have died, and they might need to look into whether that is accurate or not and let us know. And also then it informs them in terms of not having to contact these people in their engagement in care efforts. NHMR and the definitions have also impacted policy. We have started a national late diagnosis review process, in part because of the high number of late diagnoses that were then affecting outcomes and mortality among people living with HIV. And this late diagnosis review process allows us to identify gaps in HIV diagnosis, HIV testing, for instance. And we are also monitoring HIV-related deaths as a target for ending HIV mortality, so AIDS mortality, but also HIV transmission. And this is all part of the work that we're doing to end HIV transmissions in the UK. Finally, it also helps us with our research priorities and then to kind of like help with furthering policy and surveillance. And for instance, we have done work on engagement in care and the impact of engagement in care on mortality. So we noticed that a number of people who acquired HIV perinatally had worse outcomes in terms of mortality. So we're trying to understand how we can best support this group of people. And then it also helps us look at specific causes of death that we can see maybe we have some issues in the UK specifically. So it might be cardiovascular disease, it might be COVID, or other respiratory conditions. I'd like to thank our wonderful team at UKHSA and all our colleagues that helps us do this work, and people living with HIV who support us and allow us to support them in the best way. Thank you.
Thank you. Thank you very much, Vernie. For us, it's really a pleasure to have you here to discuss cause of death and mortality, because in the region, in particular, in Latin America and the Caribbean, it's very difficult to have real figures about the numbers of cases that can be attributed to HIV, and it's very difficult also. I mean, if it's difficult for cause of death because AIDS, you can imagine that the other potential preventable HIV-related mortality is more complicated to have this picture very well. But still, what we know that the majority of the death still are because opportunistic infection. So it's a long way to go. And I really thank you. So, and thank you very much. I will ask all the presenters to open the camera. We will start the session for QA. There's many QAs, and also we have a problem, a slight technical problem with the presentation of Selena that interrupted at the end of her presentation. So I will ask Elena to summarize the end of her presentation and conclusion, and if she wants to finish before starting the QA. Elena.
Thank you, Omar. So I understand that I disconnected when I was talking about the monitoring. So all I wanted to say is that in our recommendations, basically, we monitor the TPT initiation and TPT completion, and there are certain guidance and guideline documents that you can use to look how you better monitor that, and there is going to be an update this year. Last but not least, it's very important to remind you that you should rule out TB, and all those newly diagnosed with HIV and those that are newly coming to re-engage into care should be at least offered to be screened for TB and also offer TPT if they have not been treated before. What is important to mention is that there are many screening methods, but a chest X-ray is not considered a barrier to initiate preventive treatment. Definitely, a chest X-ray may be used in TB screening for people living with HIV on ART, but the lack of X-ray should not be a barrier of initiating treatment. And the test for TB infection is not a requirement, so you can go by checking the symptoms, possibly applying one of the screening and diagnosis methods, ruling out TB, and start TPT. On your screen, you can see again the regimens. The three with the star, with the red star, are the strongly recommended ones. We still have the 6 months treatment and those 3 months treatment options. There is a lot of research still going on for having the 1 HP benefits studied for specifically in use of people living with HIV, but for now we are not having enough evidence to say that this may be the preferred option. So to conclude, regarding the TPT strategies, what we've seen in our multi-country project is that we definitely globally may need to work on offering better monitoring tools for TPT and helping countries to actually report not only the initiation but also the completion rates. The countries should update national policies, especially reminding those that maybe did not see the news, but in September 2024, a new rapid communication by the Global TB Department was issued on TPT regimens, specifically used also in the drug resistance, in the context of drug-resistant patients. So that is something new, and also consideration for the dosing of the antiretroviral treatment and TPT. We definitely need to boost the support of collaboration of TB and HIV services and start and offer more actively the TB screening and ruling out TB and offering TPT for those that are newly diagnosed and newly re-engaged in care if they have not been treated before. And definitely scale up the differentiated care models where TPT can be offered at the points of care of ART, because there are definitely good benefits, good programmatic benefits, and this is something that we've seen in the multi-country project. Thank you very much, and apologize that we encountered some connection issues even in Geneva. So bear all with us, and I'm ready to answer your questions. Thank you.
Thank you, Elena, very much. So we will start the QA session. There is a lot of questions, and how many of these questions, I mean, very important questions that really are showing the need to continue with this kind of webinars. And there is a comment from Rosa Morales from CDC in Central America. How can we use mortality monitoring for prevention of new infection? And I think that monitoring mortality will be probably not the objective is to prevent new infection, but it's really to eliminate HIV. And when we talk about eliminating HIV/AIDS, we talk about reducing new infection and reducing mortality also. And as we know, it's very complex. But we will go back to this question specifically for Veronica. So I invite Shanti to start with the first question. Shanti, we have Ajay, we have Alessandro, and Joe, and Veronica, and Elena. So if you could start with the first question, and then we will be sharing, comment on that.
All right, great. Thank you, Omar. Again, thanks to all of our presenters. Let me see. The first question is on TPT. So can you do a quick refresher in the case of resistance with TPT as part of the prevention in PHAs? I don't know how quick that refresher could be.
Well, I will be trying to be laconic. The refresher is very clear. There is, as much as it was, the attempts were trying to find any association with the resistance for a later TB treatment. Once people are taking TPT, this was not confirmed, so this is a myth. There is no evidence, there is no fresh and no old evidence that TPT uptake in the contexts of TB patients may be associated with higher resistance. Moreover, our colleagues in the Global TB program, they are having many tools that countries may use to monitor resistance, and there are certain protocols, but those activities also in countries are not showing that the resistance is highly increasing. So definitely as a quick refresher, I can say there is no resistance associated. I also put a link to the questions and answers on TPT in the chat. Please use that because that question also comes up in the Q&A and you can see the official answer also of WHO on the website. Thank you.
Thank you. Thank you, Dr. Elena. Omar, you may have some comments on this question slash comment that there is a question as to why there's a lack of information on advanced HIV disease in the Caribbean. Like, why is this the case? And so what is the limitation in terms of research, and can you elaborate on any strategies to address this gap? I know you have been doing some work, Omar. I wonder if you can, maybe you can share, and as well as our presenters could share on what are
Thank you, Shanti. I think that no one else better than you to talk about the Caribbean and all the knowledge in HIV knowledge, but I will introduce a little. I think we are working very heavily in Latin America and the Caribbean, and we are glad to say that we will be in meeting in the Caribbean in the next week to unpack a project specific and focus on reducing HIV deaths through with the support of UNITAID, and this project will be, in this meeting we will convene the nationalist program, and we will try to focus on why there are so many gaps that can be, and how we can support, or PAHO can support some of those the nationalist program to reduce some of the gaps. But obviously we must say that even being the Caribbean the second region in prevalence, is one of the regions that receive very few international support compared with other regions. Latin America as a whole has 10% of the new HIV infection, 8% of the infection in total of HIV infection, but only 3% of the global fund and only 1.5% of the PEPFAR money in general in Latin America and the Caribbean region. So much more investment, much more effort, domestic investment also, and support of researchers in the area are needed, but also a lot of more work with civil society. There was a comment from an anonymous attendee about the need of the autonomy and updated information and prevent their own death from advanced HIV disease, and this is what we need, because also the Caribbean is one of the areas with much more stigma and discrimination, and still there are some countries where same-sex relationships are still illegal, and there are many other barriers for accessing the care. So comment like that were made by the Lena about the need of integration and the standardization of the assessment for HIV and also for opportunistic infection are relevant, in particular in the Caribbean also. So thank you, and I think that you might continue this comment, Shanti, because you are for many years working, researching, and also implementing in the Caribbean. Thank you.
Yeah, thanks, Omar. I wondered if you wanted to mention some of the efforts around the histoplasmosis research that's currently ongoing. I know that you have been leading that with some of our Caribbean colleagues, so yeah.
Okay. Okay, this is our initiative, a PAHO initiative focused or trying to integrate all the testing for advanced HIV disease patients or patients with symptoms to try to screen for in the same moment with point of care tests for histoplasmosis, cryptococcosis, and tuberculosis, and those efforts were implemented in Guyana. I see there are many people from Guyana. Thank you for the effort. And in Trinidad and Tobago also, thank you very much. And now soon to start in Dominican Republic. A preliminary result from Trinidad and Tobago that we expect to have published very, very soon shows that 30% of the patients with advanced HIV disease will have some opportunistic infection, 10% of them will have histoplasmosis, and 15% will be tuberculosis, a little less than 10 cryptococcosis. So those approach are very cost effective, and even if the test for histo is still quite expensive compared with other tests. I mean, it's a test that costs more or less between $7 and $10 while tuberculosis test is 3.5 and an HIV test is $1, you know, for serology for lateral flow assay. So a lot of room for improving the access and reducing the cost can be in the future if the need for volume increase. So we can continue with the speakers. Shanti, I don't know if you have other questions for other speakers. Thank you very much.
Yes, I think there are a few more questions. There's one for Joe. In the case of a pregnant patient with AHD with cryptococcal meningitis, is treatment the same as for a non-pregnant patient?
Yeah, thank you. So it's a difficult question. So other than amphotericin, the drugs that we use to treat cryptococcal meningitis are contraindicated to some extent in pregnancy. So both fluconazole and flucytosine are teratogenic. So flucytosine interferes with your DNA synthesis, and fluconazole has known teratogenicity. However, if we don't use those drugs, the mortality risk from cryptococcal meningitis with amphotericin alone is probably 50 to 60%. So our feeling is that nearly in every case, the risk benefit is in favor of using the conventional treatment for somebody with cryptococcal meningitis because your priority is to save the life of the mother. There are obviously a few exceptions to that, but nearly always we'd recommend the same treatment in pregnancy as not in pregnancy. Now, in the context of cryptococcal antigen screening and very early cryptococcal infection, the risk benefit may change a little, and that needs to be dealt with on a case-by-case basis. But really, you can't deprive pregnant women of life-saving drugs because you're worried about the baby in the context of a disease that carries such high mortality.
Mm-hmm. Yeah, excellent. Thank you. Thank you, Joe. Omar, I think there's some questions in the chat section, so if you can take a look at those. In the meanwhile, I have another question for Dr. Elena. The countries that you spoke about, our participant is asking, in those countries, did they continue to have childhood vaccination for BCG?
Well, thank you for this question. No, in our project, we did not actually target to look at the BCG vaccines and the vaccination as a strategy. So in general, we basically focused on implementation considerations for scaling up the three HP and the shorter regimens and updating policies. So the vaccination was not part of that.
Ajay, we have a question that you respond in the chat, but I wanted you to expand and elaborate on this question about the risk of advanced, among patients with advanced HIV disease, the risk of opportunistic infection, the impact of viral suppression or not, And also, I want to see your opinion about how about tuberculosis and histoplasmosis on patients with more than 200 CD4, because there is a in the paper that Alessandro showed, the 28% of the patient with histoplasmosis and HIV had more than 200 CD4. So maybe the approach could be more like tuberculosis for screening or something like that. What are your views about those points? Thank you.
Yeah, thanks, Omar. I think one of the main things is that, at least as far as CD4 and viral load go, I think it's important to recognize that they represent they're measuring two different things. And I think often there is a conflation that these two tend to go hand in hand and, sort of correlate with each other. And while that's sort of largely true in the sense that if somebody has a suppressed viral load, they're likely to be, the immune status is likely to be better. It's not always true because it's a dynamic situation. So more often than not, people who start receiving ART for the first time, particularly with the dolutegravir-based regimen, would suppress their viral load quite rapidly, but often the immune system doesn't restore quite as fast. So more often than not, you may have somebody who's having a fairly low viral load, but the immune system might still be in the process of recovering. So I think it's important to recognize that we shouldn't try to keep making inferences with the two. And I think the scenario that the person gave in the chat was, sort of was a suppressed, so high viral load, I think, and low CD4 count. And often what you see here is in the case of, say, treatment failure, you might see an unsuppressed viral load and also advanced disease, particularly if it has been occurring for some time. And this also results in a phenomenon which has been documented extensively, which is known as immune discordance, where somebody would have a high or a low viral load and sort of the opposite of what you would expect the CD4 to be. And I think it's an important point to acknowledge. And also, I think a lot of the studies that we've looked at, particularly in terms of prevalence of advanced disease using population-based surveys, I think the challenge is that we can't necessarily distinguish at what stage of treatment these individuals were on in order to clearly sort of demarcate if really if they have advanced disease or not. But we do know that a number of people in programs do have suppressed viral load, have been taking ART for quite some time, but still meet the criteria for advanced disease. And I think this particular group we know less about, and I think that's something that we really should be we are interested in looking at. And because we do believe that the risk of developing OIs might be different in that very specific population group, but I think you need to have clarity in your data sets if you're looking at this, that is in fact the population you're looking at. Because again, if it's cross-sectional, you can't really make that distinction very clearly. And I think in terms of histo and TB, I think currently our recommendations actually support sort of the sort of compensation, shall we say, because I think we do allow for concurrent management of histo and TB. We also prioritize essentially starting TB treatment straight off. And I think it's also more likely that an individual would get screened for TB, perhaps more than, say, histoplasmosis, unless there was a clear policy in place in a program. So I think that's something that we should probably look at. And it also doesn't necessarily, I think it's related to a point that I raised earlier, where we were also looking at doing a scoping exercise for what routine screening for histo would look like, because then that would help capture this sort of case where you would have on a higher CD4 bound. But I think it would be interesting to see, perhaps read the paper in detail from Alessandro, I think. But yeah, I think that's what I had to say. I think at least the recommendations do sort of cover this problem, but I think we need to know a bit more, considering it's quite a large percentage. Yeah.
Yeah, thank you, Ajay. Alessandro, you want to jump and comment on or elaborate on this about risk of histoplasmosis and tuberculosis and co-infection with tuberculosis and histoplasmosis management?
Yeah, well, I think this is one of the most difficult situations we have to deal with, because in some studies it goes up to 40% the proportion of patients with co-infections between TB and histo. In theory, we should not use rifampin which is the first line therapy for TB, in association with ITRA. but many people do, and some others, they increase itraconazole dose, some others, they change TB regimen, some others, they use rifampin and they change, they don't use itraconazole, they use like amphotericin B twice weekly. So we don't really know how to best treat these patients. According to the PAHO guidelines, we should offer patients the first-line therapy for TB and use an alternative treatment for histo. But I'm not quite sure this is the case for every patient. I think for some patients, histo is the most important disease. So it's very difficult to deal with this situation.
Yeah, yeah. Thank you very much. There is a question for Veronique. And the question says, how do you manage so many information systems to do the deduplication analysis? And I will ask also to this question, Veronique, what was the impact? What information could be implemented to really change things, to improve the system, to reduce the deaths? That this is ultimately what we want.
So in terms of how we match all these different sources, we have a number of identifiers that we can use, and we're quite lucky in that our main HIV surveillance has information about the surname of the patient encoded in a way, so it's a sound X, the initial, the date of birth, and also the date of diagnosis, and the gender. So these are the things that we use across the different sources in order to match. Matching is, of course, never 100%.
Yeah.
Never. And often we are missing data, or the surname is different. In the UK,
you have more or less 20% that didn't match. 20,
yes,
20.
so yes, between an HMR. And so what we have to do is then go back to the clinics. So these exercises are great from our point of view because it keeps the relationships with the clinicians and the clinics. It allows us to go back to them and say, this is important work to us. We need to know a little bit more about this patient. Is this a new patient? Is this someone you had seen before? And then sometimes we can actually match that patient with a patient that was elsewhere in our database, but maybe wasn't recorded in quite the same way. Or we might get information from other sources that will tell us that we think a patient has died, we match them and it's a mismatch. And so we can go back to the clinic and say, well, we have this match, we think the person might have died. Do you know if this person is still being seen? And so this allows us to make sure that our database, not only in terms of mortality, but in terms of the database in general, is more accurate and supports the clinics. All of this information then also goes back to clinics in terms of the work that they do for engagement in care, the work that they do. We provide data on their deaths. So we do kind of like go back to clinics with a lot of information to thank them about, just for them to understand how important it is to us, and that we want them to also have that data for their own purposes.
And how this inform or change policies or interventions after the publication?
Yeah, so I think this is where I was saying earlier, I think when we started doing the National HIV Mortality Review, a large portion of the deaths seemed to be among people who had a advanced HIV, so or late diagnosis. So that's where we started the late diagnosis review, to kind of then inform our understanding of where the gaps in testing were, or prevention, among those particular patients, and what we could have done differently to avoid mortality. And so this is a project that is currently ongoing. Again, it's a voluntary project, so clinics have to have the time to provide us the data, and it's not 100%, but it does then inform policy and it informs our national guidelines, clinical guidelines, for instance. So all of this is then used elsewhere. So late diagnosis is one, but we also kind of like monitor trends in different infections that might have caused deaths. We might go back to clinicians. We present this data a couple of times a year to the clinicians that are involved in mortality, to also let them know, okay, well, we've seen a peak, say, in respiratory disease in the last 2 years. Is this something you've noticed in your clinic? Are there any other reasons? Should we explore this a little further? And should we highlight this to BIVA, which is the HIV Association for the UK? So this then kind of like helps us monitor trends and inform other parts of the system to ensure people living with HIV get the best care.
Yeah, thank you. Because any preventable death, by definition, is something that could have been avoided. So it's a long continuum of advanced HIV disease care. I mean, to diagnose earlier, in the late diagnosis, to put in treatment earlier than the not treated people, to re-engage of people that was loss of follow-up, to screen for opportunistic infection, for treat opportunistic infection, and to manage a patient in USA intensive care or wherever, and then of the death. The life. So it's
Exactly.
incredible complex how to split everything and propose intervention, but it's something that is very well, I mean, I think it's very important. Thank you. Thank you very much. Shanti, can you go to the next comment question, please? Do you have any other comments or question?
I'm not seeing any more at this time, Omar.
Okay, so maybe we can go in a round of final remarks and comments with all the speaker, and then maybe a final remark from your side also to
Sure.
to summarizing the situation in the Caribbean and the situation also on all the presentations. So we can start with Ajay, summarizing and making some remarks about what is important from the presentation and what is the next step we will follow. Go
Yep.
ahead.
Thanks, Omar. I think needless to say, I think one of the attendees had made a comment about the lack of data in the Caribbean, and I think that's a clear priority going forward. Needless to say, I think having a better understanding of how AHD is presenting typically, I think we have a really good sense now, at least in the East Southern African region and to some extent the West African region, what is happening in terms of advanced disease. But I think we do need clarity in the Caribbean region. Also, the health systems and structures are different. So the way that, for example, the various tests and diagnostics that we have available would be implemented would vary from how we would typically look at, say, CD4 point of care testing in sub-Saharan Africa. So I think these are some special considerations that we need to take into account. And I think, needless to say, we do have a meeting coming up in not so long. So I think these are all very relevant things that we can carry forward and talk about. And also, I think, sort of encourage that people look into these research questions as well. Thanks.
Yes, thank you. Well, a lot of expectancy for this meeting. Hopefully it will went good. Alessandro, do you want to make some comment or remark what is needed in addition to what you already commented, please?
Yeah, thank you again for the invitation. I think histoplasmosis is a major issue for people living with HIV, but it seems to me that the message is not going to the HIV community yet. We did a small study looking for the major HIV conferences in the world in the last 5 years, and only 0.8% of the contents of the conferences, of the HIV conferences, are dedicated to fungal infections. It seems that people are discussing antiretroviral therapy at all times, but we need to look at the opportunistic infections because people are still dying from that. And in terms of histo, we need access to histoantigen testing and liposomal lymphotransfusion B, and we need to put pressure on the governments for implementation. That's my view. Thank you.
Thank you, Alessandro. We get this point, and hopefully we will have more options for liposomal lymphotransfusion soon in order to expand the access to this drug for people in particular with histoplasmosis. Elena?
Yeah, so as a take-home message from my presentation is definitely to work on making accessible and available the shorter TPT regimens, the 3HP probably, and also explore the other potential regimens that may be better for adherence to preventive treatment and monitor well the completion rates, not just take the pills home, but try to find ways to monitor that the treatment is completed so that we prevent those TB infections in people living with HIV. And definitely, if you have newly diagnosed HIV, people with HIV, or those that are newly coming to re-engage in care, at least that part of your patients, put them on TPT, offer them TPT after you screened for TB and if they have not been treated before. Thank you.
Thank you, Elena. I would say that the doctor probably are the most important barrier for starting TPT because it's in the experience, and when TPT is offered by nurses, it's more easy to be prescribed, and doctor usually worry about resistance, about toxicity, about how about if the patient is having a latent TB or active undiagnosed TB. So very different situation. And doctor, we are the doctor that we need to change this in order to save more life, because continue TB being the most important cause of death and HIV. Thank you very much. Joy, what are your final comments?
Well, thank you. Just echoing what's been said. I think it's getting the message across that advanced HIV disease remains a major problem, that a very significant proportion of our patients are presenting with low CD4 counts and getting opportunistic infections, and we need to ensure they have access to the treatment they need. And the first step in that is demonstrating the disease burden, getting some data out there about the epidemiology, and showing that you need these treatments for these individuals to receive. And the reason I didn't present any cryptococcal data from the Caribbean is because there is none. So when you publish yours, Omar, it will be the first, I think.
Thank you, Joe. Veronique, how about your final comment and your expectancy to work in Latin America and the Caribbean in those topics also, and to collaborate with that?
Yes, no, I think collecting and analyzing data on mortality is really important and can have a huge impact on many aspects of the continuum, whether it's prevention or care. But of course, you need the data, and that's one of the biggest hurdles, I think, in a lot of, even for us, where we have an amazing surveillance system. It is still tricky, for instance, to match people. So I think the definitions that were created through this consensus group were quite pragmatic and hopefully can be applied to different systems at different levels. So it's definitely worth like trying to start looking at them and see what you can get out of them at local levels in different places and in the Caribbean.
Thank you very much. So for closing, my friend Shanti, what are your comments, your context for the Caribbean, all the presentation on the situation, and also the information that can be available? Thank you.
Yes, thank you so much, Omar. Thanks again to our presenters. I think we did start off this session, Omar, with a statement from you that there's a high burden of advanced HIV disease in the region, and we know this. And of course, the related mortality. And what came across, I think, from all of our presenters, that this is so despite the increasing number of people who are being placed on antiretroviral therapy. And so I think this webinar and many of the other initiatives, including the research that you spoke about, Omar, really is an opportunity for us in the region and for us globally to be able to address the issues around advanced disease. I want to thank all of our presenters. Thank you, Dr. Ajay, for really taking us through the expanded package of care for advanced HIV disease. And starting off us nicely, in fact, with a definition of advanced HIV disease. And again, what came through is that the burden of advanced HIV disease, despite the number of people that we're putting on antiretroviral therapy. For sharing WHO research landscape, looking at the importance of CD4 testing, clinical staging, point of care testing, so that we can adequately diagnose and manage advanced HIV disease. I want to thank Dr. Alessandro for talking us through the screening, diagnosis, and management of histoplasmosis among people living with HIV, and really emphasizing that the awareness is needed. I think we have seen this in the region. We oftentimes are faced with patients and we're thinking that this is TB, and I know that you have raised the point that in fact that the mortality that you're seeing that's related to histoplasmosis is even greater than the mortality for TB. And so the awareness that is needed, and for taking us through your experience using the antigen testing and concluding that this is really important for us to have access to antigen testing so that we can make timely diagnosis for patients with histoplasmosis. Thank you, Dr. Elena, for taking us through some of the lessons that you've learned from countries that are scaling up shorter regimens for TB, and really underscoring that there is a need for support from our partners, WHO and PAHO, to be able to continue to harmonize their monitoring and evaluation platforms. It was interesting to see that there is still the need for updating of national policies and national guidelines in order to scale up the uptake of shorter regimen, treatment regimen. And so in the Caribbean, we're also looking at that. Of course, we're talking about HIV as well, and so the need for continued close collaboration between TB and HIV services. I want to also thank Joe for interesting presentation on the new evidence in the management of cryptococcal disease. We know that it remains one of the commonest cause of adult meningitis, again, despite the access to ARVs. And thanks for presenting the evidence on shorter course. I thought that was really very interesting, considering some of the challenges we face in the region, not only in terms of managing our patients with amphotericin B deoxycholate, but also access to the medicines. And so for really taking us through the evidence on shorter course high-dose treatment that is seen to be non-inferior to the conventional 2 weeks treatment that we normally use with amphotericin B deoxycholate. And of course, sharing with us one more time the significant side effects associated with the use of amphotericin B deoxycholate. I think that the research that was shared in terms of the single high-dose ampicillin given with flucytosine, showing that this is non-inferior, it's really presenting to us a practical regimen, a regimen that's easier to administer and better tolerated. But it's also saying to us that there is important implications in terms of how can we scale this up as another regimen for treatment. And finally, I want to thank Veronique for talking us through how and why to measure the causes of preventable HIV-related deaths at a national level, sharing data and information from your own practice to really demonstrate the point of the importance of monitoring. And sort of in conclusion, I know that Omar, you shared a little bit in terms of the ongoing research on adult HIV disease research that's happening in Guyana, Trinidad, and some of the other countries. And like Joe, I look forward to those findings when they do come out. But yes, there are ongoing efforts to be able to update policies, update guidelines, be able to bring on board antigen point of care testing for the diagnosis of of some of the advanced HIV diseases, and to be able to better manage our patients. And so despite the fact that it still is very significant in the region, and I know globally, there are ongoing efforts. So the webinar, this morning's webinar, is a good example of some of the initiatives that we're onboarding. And as you know, we will be talking more about advanced HIV disease, an initiative that's led by the International AIDS Society and PAHO in collaboration with PANCAP in the next 2 weeks with our Caribbean practitioners. And so again, we will be going deeper into how do we better manage advanced HIV disease in the Caribbean, and be impacting on the mortality that's associated with advanced HIV disease. Do look out for some of our additional webinars, some other webinars where we'll be continuing the conversation on advanced HIV disease. And so again, I want to thank all of our presenters, very comprehensive, very up-to-date knowledge and information that has been shared. And so on behalf of PANCAP and the entire PANCAP partnership and our Caribbean stakeholders, thank you very much to IAS and to PAHO for collaborating with PANCAP on this. I think that's it for me. Omar, over to you.
Thank you very much, Shanti. Thank you, Julia Banyan, Andrew Chen, and Africa Ortega, and Laura from IIS also, and all the participants. So please, thank you everyone for participating. The recording will be available soon in IIS platform and also in the PAHO website. And so we wish you a nice morning, afternoon, or evening, depending where you are. And thank you for connecting. Thank you very much. Over to IIS. Please give us the feedback and see you soon.